So why evaluate formatively? Well, evaluation summatively is often carried out too late, making it difficult to modify an intervention. And by the time the report has been written up with the summative evaluation, it may well be that an intervention is finished, the funds have been withdrawn, and you know, that's the end of it, and perhaps our report gets shelved somewhere. I mean, we hope not. But formative evaluation helps us to develop and improve programs at an early stage. We can then influence, and it's a valuable resource in developing more effective health programs, for instance. Next slide. There are some challenges to this, which I'll go through in a moment, but what's the practice? And of course, this is a real kind of introductory session. So if you do want to know more, please get in touch with me. But just have a quick look at that. We can define the practice as proactive. It's used to then seek clarification. It can be interactive, or it can be used for monitoring. And these various stages take place at different points of the project, and they have slightly different aims, and then use different methods at each stage. Predominantly formative methods can be qualitative because we are seeking to understand, and the data that we use to measure and draw conclusions on may only become available at the summative point. However, for the monitoring elements of formative evaluation, you may have heard of run charts, things like tracking the budget, tracking the time taken, quantitative questionnaires, dashboards, observations, they are all used. There's more interactive methods, the types of methods that really I'm aligned to, so semi-structured interviews, focus groups, project diaries. There are some really fascinating methods which use participant-generated data, so you can get participants to take videos of non-confidential settings, use voice notes, even something more creative like drawings and sketches can all be used and brought together as evidence of what's going on in a project. Yes, let's go on to the next slide. I don't want to overrun. Thanks, Ben. So some of the challenges of this. If you take away one point from my presentation today, is what's key in ensuring that formative evaluation works is managing relationships. And often this isn't widely written about in the literature yet. The relational element of how well we get on with our evaluators or with the people we're evaluating is really quite important. And even if we don't get on well, that's still something to note as part of that formative work. So there are power dynamics that may come into play. There may be lack of trust because you've got an evaluation team coming in to evaluate something that can breed a bit of resistance. People feel very protective, rightly so, about their interventions. So how do we build that trust? And that usually does take a bit of time to embed. And it can be relatively expensive to do formative work because there's an element of embedding oneself in the field, of getting to know the intervention and to build that trust and build that reflexivity, so reflecting on how things are going, which takes time and can be expensive. Okay, next slide. The origin of some of these challenges is, for some, this is a new way of working. It takes time to get used to. You may be evaluating a team you don't know, so there's a lack of pre-existing relationships. And it's not clear what the boundaries are. And the boundaries are quite blurred in formative evaluation because you're feeding back as an evaluator to support the intervention. So you're no longer this objective observer that's very much on the outskirts of what's going on. You become part of the project itself. And that takes continuous renegotiation of boundaries. Contractual relationships may need to reflect this formative way of working too. So what is stated contractually, and then of course you may know about the psychological contract, which is all the bits that are unwritten and how we work with one another. Academia, so academics may become evaluators. You know, lots of academics gain contracts to evaluate parts of health and social care. and they may not quite have that understanding of the demands of service delivery, and service delivery might not have quite the understanding of evaluation. And that's fine, you know, we do slightly different things, but part of the formative work helps us meet somewhere near the middle, where we develop an empathy for one another and we develop shared values of working. There can be a sense of surveillance, of being watched, you know, because we're kind of quite ingrained as evaluators in what's going on. So one needs to nurture an openness of not only when things go right, but also an openness about when things go wrong and learning from mistakes. Next slide, please, Ben. So opportunities, formative evaluation can really help resolve varying expectations about what an evaluation can and can't do. I think that's quite important because I don't mean to put them as two sides, that's a bit of a false dichotomy, but sometimes the team that's contracting you to evaluate, you know, they may be very, very ambitious and yet the data aren't quite available, or vice versa. So formative evaluation works helps you have those conversations iteratively as you're going along about what the evaluation can and cannot realistically provide. You can negotiate priorities, you improve communication, and through trust building, it may well be that this helps you negotiate access to carry out the evaluation work. Next slide, please. Gives you an insider perspective, gives you a perspective into the richness of organizational life. You can build trust, mutual understanding, good communication, and have a real understanding of the process and context over or alongside the summative sense of outputs and outcomes. And the last point I want to finish my part on is think of this dialogically. So again, I'm taking words here from pedagogy. But when we say dialogical, it's about the dialogue that we have. So when we think about teaching, teaching used to be quite teacher-centered and authoritative. So the pupil, you know, was told what to do. We've moved away over that and over time. And those of you homeschooling, you may get a bit of a sense of that. But we've moved to something far more dialogical, where we communicate. We become more student-centered. And therefore here we're becoming project-centered. We're becoming intervention-centered. And we're developing a sense of teamness. So it's an approach which combines the voices of the researcher or the evaluator, whose knowledge is based on scientific analysis, with the voices of those whose knowledge is based on personal lived experience. And I think that's the key takeaway point here, the benefit and opportunity of bringing those voices together to generate a cohesive insight into what it takes to make a project in health and social care work. Thank you. I shall finish there. And I would like to introduce my next speaker. Delighted to have Phil Miller with us today. He has wide-ranging clinical and academic experience, which is centered around emergency care. As a nurse, a researcher and a manager, he's helped to deliver a large number of trials and studies with emergency and critical care, and more recently undertaken evidence reviews, evaluation planning and reporting. He works across the East Midlands for the East Midlands Academic Health Service Network, and has worked in projects for public health, mental health, technology enhanced care, leadership training. He's interested in achieving rapid adoption and spread of innovation with demonstrable impact for NHS patients. And he also has an interest in synthesizing quantitative and qualitative evidence to make it useful to the NHS. And Phil also says he loves numbers, but a bit like me, he doesn't feel that numbers are enough. So I shall hand you over to Phil now.
Wow, I'm great, aren't I? It's yes, it's amazing when you list that sort of stuff. Yeah, so we'll talk a little bit about ourselves because Amy's also on the call. So Amy Clark, who I work with in a research group that's based within the emergency department in Nottingham, she's also joined the call. So it was Amy and I that did an evaluation that I'm going to sort of base my little talk on. Maria's covered quite a lot of things, so I've sort of chosen to take some kind of choices in effect that we had to make and hung some sort of thoughts on those about how we did our evaluation. So go to the first slide, and I'll introduce some of the organisations that were involved. So we, Ben, sorry, you'll have to click through. I always put animation in and then forget. So if you can go back to the first slide, please. Sorry. And then that's the only animation. Right. Okay. So we've got all the logos. The logos are good. So, so Amy and I undertook a qualitative evaluation looking at the youth violence intervention program that's designed to work within emergency departments and major trauma centres in the NHS. So that intervention itself is delivered by Red Thread. So I'll probably refer to those as the delivery team or the implementers. And Red Thread are a youth charity that have gradually spread this intervention, which takes youth workers and puts them within the teams working in emergency departments and major trauma centres in the NHS. And they proactively seek to support children and young people. So from the age of 11 up to 25, they'll support them in where they come into the A&E department after victimisation or violent injury, and their intervention then lasts for up to about 3 months, taking the child back out of the hospital and embedding them in community services or whatever they need. So we work within a thing called DREAM, which is the Department of Research and Education in Emergency and Acute Medicine in Nottingham, and that's where Amy and I are based. And that's within Nottingham University Hospitals Trust. So they were the hosts of the evaluation, and we were based in Nottingham for the evaluation. So if I could have the next slide, please, Ben. So the first dynamic we had to negotiate, I think, when we were asked to do this was how the scope of the evaluation effectively and what we were going to try to encompass within the resources, because we had obviously relatively limited funding. Neither Amy nor I were on this full time. So we had to think about that kind of practical aspects. We also think about the funding that we got available for, and also how we could actually encompass an evaluation of 11 sites. So obviously, clearly, we couldn't do justice to 11 sites. What we wanted to do was focused on our host site, and we tried to talk to NHS staff and people in Leicester and Birmingham, other potential sites. So this narrow versus broad is actually an initial dynamic you have to address before you start, and so that involved us with our literature search, deciding on, because it's such a broad topic, what we were going to focus on. And obviously we were interested, the brief was to look at how this intervention could spread within the NHS. So we wanted to focus very much on the sort of Home Office violence policy in the UK, but how it related to the NHS. We wanted to look at how the intervention had already spread, and what features of the NHS, what features of the landscape had enabled that and hindered it. And so we focused on that kind of relationship with the NHS. We had a fixed time period, so we had roughly a year for data collection, which sounds a long time, but trust me, it isn't. We also then got we also got pushed off track by the advent of COVID. So there were always unexpected issues, but broadly speaking, we took about a year. We did our literature review, and then we started to think about, as Maria had pointed out, some of the dimensions, trying to reduce the intervention into something that we could grasp, because neither of us were specialists in criminology or youth violence. And so we needed to sort of understand what the intervention, the nuts and bolts were. So that involved looking at a theory of change, which Red Thread had already developed. But then we, as part of the formative work, we tried to push them in the direction of developing logic models and other ways of expressing the work they do. And also we took some of the academic angle and tried to get them to describe the intervention in more detail. It's from an academic standpoint, one of the problems with evaluations can be that when they come to be reported, the actual intervention itself is not described in sufficient detail. And that can be a problem for non-specialist readers of reports. But we didn't do an evaluation of the impact in the sense of measuring the effectiveness of the intervention. And that's one of the distinctions of what we did from a conventional evaluation. We didn't try to measure whether the intervention actually worked. We wanted to know how it could spread and how it could embed and how it could maintain its success in that setting and in working within the NHS. So we put the sort of, this is a real cliche, but I won't apologise. The idea of patient-centred care is important, but I think for evaluation, it's really important to understand the patient, because you then can understand what you need to evaluate. And in this case, what I mean by that is that we had to understand that the intervention was conducted within the hospitals, but very, very much embedded within the community. And so everything they did with the child or young person in the A&E department was with a view to them going back out into the community and re-engaging with education, re-engaging with mental health services, that sort of thing. So it's an easier way to think of the system if you think of the patient, because then you can understand which bits of the intervention itself have to connect with which other bits. So if I could have the next slide, please, Ben. So our next dimension, if you like, was independence versus embeddedment, if that's a word. And as Maria has pointed out, there is an issue, and sometimes this is much more acute for formative evaluation, because by its very nature, you are quite embedded with the team, you have to work with the team, and you are constantly feeding back your results. We'll talk about a little bit about how easy or difficult that can be. But to be worthy of the name evaluation, there has to be a degree of independence. And with academic health sciences, I read a lot of evaluation reports of some of the interventions that we try and adopt and spread. And to be blunt, it's very clear when you can see there's been a bit of capture of the evaluation team, and that you sort of think, well, was that really as easy as they're suggesting? You know, was that so easy to get every GP practice in that particular area to sign up to something? And you can become quite skeptical. And I think it's important to try and maintain, but it's difficult to maintain that independence. If you're too independent, as Maria has alluded to, you can't get under the skin of the intervention. You can't really get to work with the team. And I think we were successful between us in getting on quite well with the implementation team, and understanding where they were coming from. And we observed a lot of meetings. We both based in the department where they were working, so we didn't get research ethics for patient contact. We had to get NHS ethics, but we didn't get patient, so we couldn't observe them in their clinical environment. But we did attend meetings, and that gave us a feel for how they work with the NHS staff, and that was really our topic. That was really what we were interested in. And this establishes what in academic terms is called external validity. You really do have to understand that your audience is going to be external to the issue to a great extent with your final reports, and that they need to understand that you were willing to look hard at something and answer questions honestly. I think obviously there's always an element of summative nature with this, and that can, as Maria again has said, that can give the team a sense that they are being evaluated themselves professionally and sometimes even personally, I guess. And anyone with a professional background understands that being examined that way can be uncomfortable. But I think it's important to establish that you are there to measure the intervention on behalf of the patient, and I think that's quite a keen. You need to be keen to make sure that that's understood. So if I could have the next slide, please, Ben. One of the other dimensions was the differences between our understanding of what we were doing and the understanding of the people doing it. And as I said before, both of us, both Amy and I, have worked in A&E. My A&E career extends back into the distant past. But our academic skills were what we were putting into practice, but Red Thread also have themselves quite a lot of academic skills and certainly an incredibly deep knowledge. And so we couldn't challenge that in a way. We had to reframe the knowledge that was there. But I think what we have to do is to explain that that there are some academic methods that are worthy and worthwhile for groups that want to examine what they're doing. They obviously have to talk to their funders, and they obviously have to establish an audience for when they're spreading their intervention. So they need to understand the perspectives of other people, and that was and that's obviously something that they're comfortable with. But when it came to actually doing the evaluation, we couldn't claim any kind of expertise in what they actually did. So we were very much observers. And what we tried to do was to understand how that played with the NHS partners and with people like the violence reduction units that have been established. That's a Home Office initiative. So again, back out into the community, who do they have to work with? What they were familiar with working with was the Home Office, and to some extent with the police and crime commissioners in various areas. They were less familiar with working with new NHS organisations, and also, as we know, the NHS is changing, and we're now in a situation where we have systematic systems for running the NHS, which are being developed, like integrated care systems and whatnot. So that was a new landscape really for Red Thread, and part of what we were trying to do was to understand how they were going to fit in with that, and who they needed to influence and who they needed to speak to get that spread working. And then if I could have the next slide, please. So what we also needed to do was decide on the scope. You'll always have to decide the scope, and as I've said, there's a difference in terms of the length of time you've got to complete an evaluation, and as Maria has said, how useful are the different findings if they only come right at the end. But what we tried to do, our choice was to try and encourage and to improve the organisation's capacity for evaluation themselves. So part of the data we analysed was their own reporting methods and their own feedback to funders. And we also looked at, we interviewed numerous sort of NHS organisations and partners, and we wanted to find out what kind of evidence they needed. So what we tried to do is move from this idea that this was a discrete evaluation that would just happened and you produced a report, and tried to think about their ongoing evaluation of their own services and how that could
Bill, you have 2 minutes.
Okay, that's lovely. So part of this is, in terms of the formative aspect of this, is to try and increase the ability of an organisation and an implementer to actually continue the evaluation once you've left. And so we talked about access to data. So some of the things that we didn't look at in terms of data, things like the hospital outcomes and re-injury rates and stuff, we still try to influence the charity to think about how they collected data, how they used that, and how they then could then build a case for, business case, and build a case of need for other departments. And they now, a final thing about the formative evaluation, which we can't say one way or another, is how much influence we actually have. As the process was carrying on, things were changing. And so what we found was sometimes things that we thought we might have suggested were starting to bubble up and starting to be put into practice. And that's part of the thing, that you have this interaction. So in summary, I think those four sort of dimensions are one of the key things that you need to think about straight at the beginning before the evaluation. And we agreed these dimensions with Red Thread before we even started our work. So I hope that's been useful. And if there are any questions, I think we were going to have questions at the end, I believe. Is that correct?
That's correct, Phil. Yeah, we'll take questions at the end. Thank you ever so much. Thank you. What an insight. Yeah, I think we're thinking about these key ingredients, aren't we, to make this work. Really great. Lots of food for thought. I'll now introduce our next speaker, Sian Howell from Southwark, South East London. She's been a general practitioner, a family doctor in London for 25 years. The clinical lead for Clinical Effectiveness Southwark that she'll talk to you about today. And this is a quality improvement project in South East London primary care. Sian has a long-standing interest and has worked for many years helping to improve clinical systems in primary care. She's interested in delivering change and improved patient outcomes through local engagement and ownership, trust, evidence, and data. So it gives me great pleasure to hand over to Sian now.
I hope you can all hear me, and my computer seems to be glitching. So Maria, could you just put a thumbs up to show me that I'm all right and transmitting okay?
I can hear you, Sian.
Great,
Yeah.
okay. Looks like some people are glitching out and some people are glitching in, so I hope it's all right. Yeah, so hello, thank you for the introduction, Maria. And if we could go to my slides, that would be really great. Thanks, Ben. And what I'm going to do is talk through the project and what we did, and then think about how the formative assessment helped us. So this is me, this is our project, Clinical Effectiveness Southwark, and it's got my contact. And if people are interested, you can go to the website, Clinical Effectiveness Southwark, and just have a look at some of the things that we do. So if we go down to the next slide, please. So this just shows you where we are. So we're Southwark, we're that little pink patch. So we're one of the boroughs in Southeast London, and we have a population of about 350,000. We are a deprived borough with quite wide health inequalities. And we have between about 35 and 40 GP practices, all of whom have slightly sort of variable performance in a way in how they support their patients, particularly around long-term conditions. It's very busy, particularly at the moment, but it's very busy. So we're very mindful that when you go to have a new initiative or a new quality improvement project, you have to be mindful about this can't be something that's perceived as additional to practices. And also that although primary care can have a significant impact on health, we're not the only sort of player on the block, and that other things need to happen as well to see the health improvements that we would really want. So if we go to the next slide, so that kind of just sets the context. Now, I was interested to see that there's a colleague from Hackney on the call. So we started our project about 3 years ago, and in the lead up to this, we were looking over the river to Hackney, Tower Hamlets and Newham, 3 very deprived boroughs in East London that were doing something pretty impressive and coming out with some of the best results nationally around blood pressure use, statin use, cholesterol use, and overall quality indicators for general practice. And they had a clinical effectiveness group model, and this is a kind of picture, and they talked about a learning system. And so we wanted to learn from them and understand what they were doing and see how we could implement that in a similar inner city borough in London to try and compete with them on some of their very good results so that our patients could get some of those improvements. So that was our starting point. Can we go to the next slide, please? So what we did is we sort of deconstructed their model, and we came out with a sort of overarching aims of having a systematic approach to addressing health inequalities, reducing sort of unwarranted variation to improve patient outcomes, making sure we were evidence-based, but really important that we were supportive and neutral. We were not about performance management. We were going into practices to help support them to deliver what they wanted to do. And there's a second piece on this slide, please. We could just click to the next little bit, and it just talks through our model. So, and again, another click, please. Sorry, I forget about these little different bits on mine as well. So we could click again. So what we do in, so there's a little middle bit, which I hope will come up. If we could just click for the next slide bit. That's it, perfect, thank you. So what we do is we choose conditions, long-term conditions, which are important to our patients in Southwark, and that importantly, we feel if we go back one, sorry, that we think are important that we can have an impact on in general practice. So we pick the high hitting conditions. So you'll see the common ones there: asthma, depression, atrial fibrillation, diabetes, and more recently we've been focused on COVID pathways. For each of these conditions, we produce a local clinical guide, which is a simplified version of the huge number of guides we receive in primary care and focused on our patient population and local services. We launched these at big educational events. It used to be face-to-face with kind of 150 to 200 people, and now they're all online. We produce clinical templates that go into the GP system. So when the patient comes in, the guide is kind of in a template which reminds clinicians what to do, and then they can enter what they've done. So we get consistent coding. That allows us to then run searches on the GP systems so that we can pull the data out and go back to practices and say, this is how you're doing for diabetes, this is how you're doing for asthma. And we do this by going into practices in a supportive way, building on often meetings that they're already happening there, to doing so that they can constantly improve, feedback from the practices, so how we can improve, refining our guides, our education, our templates, etc. So that's what we do. So if we go to the next slide, please. This kind of talks about the model that we developed. So it's quite a complicated model because we had lots of things in our landscape already. So CES is us, Clinical Effectiveness Southwark. So we work with the GP practices. So GP practices are clumped together into federations, or now PCNs. And we have 2 federations representing the 35 to 40 practices in Southwark. We have the CCG, who is our main funder, our commissioner. And then we were very fortunate to have system partners. So we talked about academic health science networks. We worked with our local one, the HIN. We had a patient and carer pathway in Healthwatch Southwark. We worked with our acute trusts, who are represented by King's Health Partners, which represent our big hospitals. So King's Hospital and Guy's and St Thomas's. And also we were partnered with the Health Foundation, who provided funding, and really importantly, they funded the evaluation through King's College London. So that's our kind of slightly complex landscape to deliver this model. If we could go to the next slide, please. So any of the achievements that were achieved in Southwark were very much a team approach, with CES producing the guides and the tools and the templates and the education, the federations going out and visiting the practices and letting them know how they were doing and supporting them in improvements that they might want to make. The CCG putting the right incentives in. So we'd say, look, the evidence suggests we really need to incentivize this part of the pathway. And they would do that so that the resources were going into the practices to deliver on this. Then clearly the practice and clinical and admin staff actually doing the work. And that's not even to mention the patients making the changes. So it's very much a team and collaborative approach, which makes it stronger, but also more complex and messy to deliver. So we go to the next slide, please. Which I can't, yes. So this is how we did. So these are some of our results. So if you go to the website, you can see the guides we produced. This is a picture of one of our templates that you would see on a clinical system. And we're having over 1,000 hits a month on our templates. We saw some really big improvements, particularly in diabetes, where we saw a great improvement on something called the triple target, which looks at control in patients with diabetes across a number of parameters. And then QOF, for those of you not familiar with general practice, is a kind of quality outcome measure for general practice across England. And in our first year, 18-19, we were the most improved in QOF in London. And we improved not only across all the clinical effectiveness clinical areas, but in QOF overall. So we were doing really well, things were good. I mean, it's all sort of dipped off a little bit during COVID. But yes, so these are some of our results, and we were shortlisted for a national award. So if we go to the next slide, please. The next slide talks a little bit about our evaluation, and I'm never quite sure. Yes, so here we are. This is our evaluation from Maria and her team at King's College London, and we had some quantitative and qualitative which sort of came together. So our quantitative results showed that composite scores for our long-term conditions improved over the 2 years. Really importantly, they improved across the social group, so they weren't. The improvement was equal in the lower social groups to the higher groups. They also commented how we then used our model to respond to the COVID pandemic and how well we did around diabetes and hypertension in particular. And then the next slide looks at some of the qualitative results, which fits more with a formative assessment. But actually, having said that, I felt very much that both the qualitative and quantitative really came together in the evaluation. So if we could go to the next slide, please. So the qualitative results talked about an implementation team being cohesive and navigating this crowded quality improvement landscape so that we developed clinical effectiveness as a brand that people recognized and trusted. that we really tried to work closely with the practices and with the Federation colleagues so that this became a very kind of collegiate approach to this quality improvement methodology. And that we also learned, and this was a big learning, particularly from the evaluation as we went along, that we'd have these very active times when we were producing guides and templates and we're very busy, but actually we needed to stop and reflect and learn. And this is where the qualitative and formative assessment was really, really helpful to us. So on the final slide, I've just, so if we could go to the next slide, please. I just had some thoughts about what worked well for us. So, and having not done lots of projects and not had lots of evaluation, to me, it felt very natural and comfortable having a formative evaluation. It felt very supportive, and having a bit of a neutral partner with all of these different partners involved in the project was often really helpful, because when they were shining a light on something, it didn't feel political in any way. It felt kind of fair and transparent. And although the evaluation team were very much this sort of neutral partner, they also absolutely felt part of the team. So coming for Christmas drinks when we were allowed to go Christmas drinks. And they felt very much kind of involved in who we were. They felt like a critical friend, and it was always done in a friendly way. And there was both kind of quite formal feedback along the journey, sort of perhaps in an interim report about how we could improve, but also some informal feedback along the way that, you know, coming and saying, did you realize that this group was feeling a little bit like this? It's probably worth having a think about this. There was some real help around the operational data. So this was the more quantitative side, but actually we were pulling a lot of data out for the evaluation team, and this helped inform how we did our own data systems and what we needed operationally data-wise to help to feed back to the practices. So it brought in some sort of data discipline for us. We had these interim reports, which were really helpful for us to stop and reflect on what we were doing and shape the way we went ahead. And that picks up on Maria's points earlier about shaping and contributing to the intervention. And the team managed to be both professional. So we had confidence in confidentiality and how they were presenting the data and the robustness of the process, while still being friendly and supportive. So it seemed to kind of work very well. And then I think what was really nice is this kind of shared success with the evaluation team. So right from the beginning, the team were involved right from the beginning. I noticed Mark is on the call. So Mark was with me when we went to the Health Foundation to secure funding right at the beginning when we were developing the project. The evaluation team were part of the team that put forward our application for the national award, and part of that is process, bringing a robustness to our application. And again, just feeling like a shared success because we were all in it together. And then really importantly for us now, as we come to the end of the project and the end of our funding, the formal evaluation of this project has helped us secure funding. And we are now from the beginning of April, the clinical effectiveness model in Southwark is going to extend across the 6 boroughs in South East London, so covering a population of a fifth of London. And so we'll be very equal with our colleagues in North East London, from whom we copied in the beginning, who are now covering the whole of North East London. And we'll have this close working relationship with them as we start to bring this systematic, aligned and supportive approach to general practice to really improve patient outcomes. So that's it for my slides. Oh yes, and that's our strapline, making the right thing to do, the easy thing to do for busy clinicians on the ground. So yes, that's fine. That's my presentation.
Thank you so much, Sian. It's really, I think, so useful to hear, to help develop an empathy, what it feels like to be evaluated. I mean, I hope you still felt, even though I was one of the evaluators, that you were able to speak freely, because it's so important to find out what's working and what isn't during that relationship of the formative evaluation.